Hi, everybody. Welcome to the living room. We're really excited to have everybody back tonight. I want to say a big shout out to everybody watching in online. Thank you, thank you. And of course, as always, to everybody in the room. We have a wonderful guest speaker tonight, Dr. Billlings, who is going to be talking about next generation sequencing. And I know I've talked to several of you about it, and we have him here tonight as an expert on the topic to let us know what it means for lung cancer patients now and tomorrow. But before we do that, we have some new people in the room. So what we normally do, oh, Elaine's here. Hi, Elaine. What we normally do is in around the room so that our speaker can know who he's talking to so he can better answer questions as it relates to you individually. So I don't know if you, I can't remember. I usually try to trade off whether I start left or right. But do you want me to go this way first? Yes. Okay. And I want to give a very warm welcome to Hugh, who came tonight. Laurel passed away, and I know how difficult it is for him. And so we are giving you a big, huge hug. So, do you want to say anything, or do you want to just pass right to Tina?
Well, yes, I will. It's
Thanks.
alive?
Yeah.
Okay. I'd like to thank Danielle and Bonnie and everybody in the foundation for the support they provided for Laurel and myself for the last year and a half since we found out about them, since Laurel found out about her cancer. She didn't survive it, which a lot of people don't. I think my understanding is that about 17 or 18% of lung cancer patients have a 5-year survival rate, whereas in something like breast cancer, it's about 89%. Now, there are a couple of reasons for this. One is the good support that breast cancer has gotten over the years, and it's gotten this because it affects such a higher percentage of the people than I think lung cancer does. Well, and since they have a very fast way of diagnosing it very early, utilizing mammography and self-examination, and that's something that the lung cancer is completely missing. One can do a CAT scan, but that's a lot of radiation, and for most people, it probably isn't advisable to take the chance on the extra radiation they're going to get from the CAT scans, unless there are people who are at high risk for lung cancer because of smoking or that sort of thing, or the family history in that area. We certainly didn't do that. Laurel didn't do that. So we found out about this very late when she was in 4th stage, and it was every place besides the lung. It was still lung cancer, but in bones and in the brain and in the liver. She got very good treatment. She survived as long as she could that way and kept cheerful. For those of you who've met her here, she finished up at home under hospice care with 24-hour CNAs, which are certified nursing assistants with her. And she passed away very quietly, sleeping the last 3 days, probably in a coma, but she would open her eyes, but only if prodded to do so. But I know she would like to, if she was here, express her thanks for the support we got here, the information we got here. So, enough said.
Thank you. And just to your point, though, more women don't survive lung cancer than do breast cancer. In 1987, lung cancer surpassed breast cancer as the biggest cancer killer of women. So it is a big disease. And there are low-dose CT scanners now that are very similar to mammograms. So I'm a big proponent of CT screening.
I think one of the reasons that breast cancer has come back and is not killing as many people is because of the use of the mammogram and the good early detection. And
funding.
And the funding, which allowed that to get its publicity it needed.
Exactly. Well, we're happy you're here and you still consider us part of your family.
Thank you.
And you're welcome forever. Right.
I'm Tina, and I was diagnosed in November of 2010, I think. I did radiation and chemotherapy and have been on Tarceva now after that treatment. It was clear, and then I've been on Tarceva for almost 2 years. And everything's been fine so far. I had a PET scan last month, and there was no evidence of active disease.
Awesome.
So, tell everybody where you went.
Where I went?
Your trip.
Oh, we went to Australia and New Zealand. That's why we weren't here last month. Sorry.
That's great.
Yeah, it was
That's
fun.
great.
We really enjoyed the mixology classes on the cruise.
And in September, we're going to Italy again.
Yay! That's awesome. That's awesome.
So-
That's great.
We're making all the rounds.
That's good.
That's real
really
good.
good. That's really good.
Do we want to go to Carrie?
Want to go to Carrie? Okay.
Hi, I'm Carrie, and I was diagnosed with stage 4 adenocarcinoma, lung cancer, in October of 2011. And I've been on chemotherapy basically since. I had some radiation first. And I recently had a CT scan and showed that there had been some progression of the disease. So I've switched from Alimta to Taxotere. And I'm loving the Taxotere compared to the Alimta as far as side effects and everything else. So I'm much happier now. And I am hoping that the next CT will show that it's made some improvement, and then had spoken with Danielle about various options to look at next. So moving forward with that, I was upset that there'd been progression, but glad to know that we've got the support and knowing there are so many options out there. So I thought I was going to make it, but next time. Anyway, nice to see everybody again.
Hi, I'm Christopher, Carrie's brother.
And I'm Jeff, Carrie's uncle.
Nancy, you want to go next? Sorry.
Hi, I'm Nancy Capelli, and I think I've said my background, but just in summary, based on my mom having lung cancer and some work done to discover it was in her genetic makeup, I had some proactive blood tests done and determined that I had this genetic T790 mutation. I found this out last fall, and because of that, I got a baseline CAT scan, and in that they found some nodules, and the largest, there were probably about 8. The largest one they wanted to take out, so I had that done in January, and it was precancerous. So it just shows that, you know, this research and finding, you know, I'm a non-smoker and, you know, wouldn't have had this otherwise. So some of this research that we're looking at in the future, you know, I've certainly benefited from it. You know, I'll get another scan in July to check up on these other smaller ones. Probably, you know, it's part of my life now going forward is to check on these. In my family, since I've been here last, unfortunately, my younger brother tested positive also for the gene mutation, and he has 3 children, so that means it could be, you know, further down the line. So he'll be getting a baseline scan. My mom had radiation in December, and I was in Alabama with her last week, and you know, she's stable for now. So she had a PET scan, so that was some good news coming from our family tree. And then we did an article that Bonnie knows about, my mom and I, for Genome Web, on this study and this genetic mutation and all the research that's being done in the area of lung cancer, and, you know, that it doesn't have the attention that breast cancer does and things like that. So if I was only as famous as Angelina Jolie, we could get a bigger platform.
And we could just lop out your lungs. But, you know, to Nancy's point, I'm going to do a little recap of what she just told you, because this is really an important study. And I'm proud to say our foundation is funding the whole study. And our group, Alchemy, our investigators across the U.S. and in Europe, are facilitating the study and doing the trials in their own facilities. Nancy's mom was tested for the T790 marker, and so that prompted Nancy getting tested, she had it. That led to a CT scan, that led to finding nodules that she had, that led to them being removed, and now watching some other nodules. This is really a good opener for what Dr. Billlings is going to talk about today, because as we find these markers, new ones, and there's a lot going on right now in lung cancer. None of this was happening 5 years ago, 6 years ago. So this is an amazing story, and I know there's some new people here that are just newly diagnosed, and I want everyone to be hopeful, because this is great news. Great news.
It is, and just to kind of touch on that a little bit further for those in the room or those that might be watching online, if you are, the inclusion criteria for this study is to be EGFR positive and T790 positive. So if you are, and you would like family members to be able to be tested for T790 and enter into the study, please email me and I will help you make that happen. So,
yep.
Next.
Right. So I'm a newbie. Heather Holcomb is my husband of 18 years, Sean. We're very glad to have found you. I was diagnosed right before Christmas with stage 4 non-small cell adenocarcinoma, so now I'm getting the lingo down. I've done 7 rounds of chemo, cisplatin, Alimta, and Avastin. I stopped the cisplatin after 4 rounds, and so I'm now on maintenance Alimta and Avastin, and I'm understanding that stable is good. We had some shrinkage, but we definitely still have tumors. I get my next CAT scan on Thursday to see if things are stable without the cisplatin. And so I'm encouraged by everything I'm learning today. So thanks.
Hi, everyone. My name's Elaine. I was a little late tonight because I just couldn't get ready in time. But I've been diagnosed since May of 2008. I have passed the 5-year mark. However, I have taken chemo of some kind for over 5 years. And I just got out of the hospital on Sunday. I think they were happy to see me leave.
I don't think so.
They don't want you to get out of bed. And of course, I'm so independent. Boom, I was up like a yo-yo. And they put an alarm on my bed so that every time I got up, this alarm went off. Oh, well. Anyway, it didn't have anything to do with the cancer, but Dr. Dormady wanted to be sure. It had more to do with lady parts, you know. So I was in the hospital all week long and very happy to be home. And this is the first night that I've been driving, so watch out. But I feel pretty good.
Get off the road.
Pardon?
Get off the road.
That's right. No, I'm very careful. I am feeling very good as far as the cancer is concerned. I have Dr. Dormady, and he watches every single thing. He's so wonderful. And I am just really feeling good after 5 years. But I have it in both lungs, and I am stage 4. So, you know, I have a wonderful family. My sons, when I got out of the hospital, they both came home with me, cleaned my house, did the dishes, emptied the cat litter box, you know, all those wonderful things that they could do. I taught them how to do all those things when they were little, see? So it pays off. But anyway, so happy to be here tonight. Thank you all.
Hi, my name is Sylvia, and I'm here with my daughter, Jen, and I will give you the mic.
Hi, I'm Jen. I am new as well, and I was diagnosed with stage 4 adenocarcinoma in non-small cell in January. My symptoms started probably in November with a cough and shoulder pain, and they misdiagnosed it as pneumonia, and I took a few rounds of antibiotics. And then I was set to do a clinical trial, and I had a blood clot in my lung, so that changed the treatment. So I just had my 5th round of chemo, of a Limta and carboplatin. And then after my 6th round, I will go on a Limta. And so far, my side effects have been pretty mild, and I'm grateful for that.
Welcome.
Hi, I'm Christy Chappelle Morris, and I'm here with my husband, Bill Morris. And I was diagnosed with adenocarcinoma, non-small cell lung cancer in December of 2009. So I'm into about 3.5 years. I've been on some form of chemotherapy for that whole time. A little stint on Tarceva. I am negative for all the big ones, EGFR, ALK, KRAS, and I'm just now getting tested for the ROS1. I convinced my provider that was what needed to be done.
And where did you learn about ROS1?
It seems to me I learned about it at this place called Bonnie, Addario Lung Cancer Foundation. And Danielle has been a great help to me at various crossroads, I call them. And in lining up second opinions outside of my provider as needed. And right now I'm on target. I'm on gemcitabine, and that seems to be working. There was some debate whether it was working or not, but those that felt it was working won. And so I continue to be on gemcitabine. I have had good. I had more trouble on Tarceva than I have had with chemotherapy, and so I've tolerated pretty much whatever they've thrown at me. And fatigue is probably the worst side effect that I've had, and that can be dealt with, and I'm working on it. But I'm active. I walk. I do yoga. I garden, and chase my husband around. So.
I want to thank this organization so much. You have helped us through all the stages and all the problems and guided us and have put us on track with the right people who have also helped and convinced the hospital to do the right thing by us. And I'm very proud to come here and listen to your stories and feel good when you feel good. And hopefully everybody in this room will be soon on the right track like we are. Thank you.
My name is Hope, and actually I'm just an interloper here. My husband had adenocarcinoma, and unfortunately he passed away. Now I work with cancer patients, and I come to these meetings because it's such an important resource for our community. I learn something important every time I'm here, and I meet wonderful people, and I'm so grateful that this organization exists. So thanks.
Hi, my name's Adar, no relation. Happy to be here. I'm with my dad.
Hi, my name is Shlomi, and actually Adar introduced me to this wonderful foundation. And I was diagnosed back in September 2012, stage 4, non-small cell, but it came with a pretty rare histology, adenosquamous, and it's not just 2 groups of cells in my case, but every cell actually features both adeno and squamous, which is pretty rare. In addition, I also have none of the target mutations. So my only choice was chemo. So 7 weeks ago, I finished 6 rounds of chemo, and now I'm taking a break. This Thursday, I'm going to see the oncologist and see what's going on.
My name is Chrissy Flassoris, and I was diagnosed with stage 4 non-small cell lung cancer in October of 2012. And back then, the pathology was squamous cell carcinoma, but recently I had a biopsy to confirm that there is also adenocarcinoma present. And I was on Tarceva for 6 months after I tested positive for the EGFR mutation. And during that time, I had cancer that had gone to the brain. So I had 2 gamma knife treatments, one in November of last year and one more recently in February of this year. And as of April 17th, the brain was clear, so that's a blessing. And on May 3rd, it was found that my cancer had progressed. So after 6 months of Tarceva, I was forced to kind of look at what my other options would be. And it so happens that, well, we're from Sacramento area, so Dr. Gandera is one of our local doctors who is really great, just on the forefront of research. And he talked to me in March about a clinical trial which actually opened yesterday. And this clinical trial has to do with combining Tarceva and a drug called XL184, which if anybody has any experience in dealing with that drug, I'd love to talk to you. There's one thing I have to do before I start the trial, which I sign papers tomorrow, but I have to make sure the brain is still clear. So that's something I probably have to do probably tomorrow or the next day. So it's been a couple of weeks since I've been off treatment and I become symptomatic again. I have experiencing some things in the lungs and breathing difficulties, pain in the back. So I'm really anxious to get started, and that's where we're at right now. So that's it.
Terry, do you want to? I don't think. Orrin wants to talk.
Hi, my name is Orrin Walker. It's my wife Cecilia. She's bashful, but she's a real good caregiver. Takes good care of me. I didn't make it here last week or last meeting because I was in Missouri. We've bought a property a long time ago, and we're in the process of tearing it down and building a new one. And once that's done and we've got it started now, I'm going to move back there. But I came back for chemo treatment, and in fact had it today. I came back 2 weeks ago, but I fell at the lake and got a tick right in the corner of my eye. And my eye swelled up. She got it out, but it still swelled up, and it was somewhat painful. But the doctor wouldn't give me my chemo until the swelling went away. It's kind of weird.
That's strange.
But things are going okay now.
Will you stay away from ticks?
Hi, my name is Terry Fry, and I'm here. My daughter, Natalie DeMarco, was diagnosed with stage 4 lung cancer back in 2010, and we've got good news last week, so we're really celebrating. She started off with the 6 or so many rounds of the 3 combo. I can't even remember now. What is it? The carbo, yeah, and Avastin and Alimta. Yep. And then she went on Avastin Alimta for about a year and a half, and then she was just on Alimta. And back in November, she had there was one spot in her lung that was still lighting up, so she went in and biopsied it, and it was negative back in September. So, but she still, her goal was to get off of chemotherapy. So she went ahead and targeted radiation to the one spot back in November. And as of the end of January, she stopped chemo, and she had a PET scan done on Wednesday. And her first PET scan after stopping chemo, and it's fine. So she's going to continue for 3 more months, and we'll get another PET scan. But at this point, there's no new growth and no evidence of cancer right now. So we're very excited. she also she's continued doing the alternative or the complementary therapy that she's done through the whole program. She does acupuncture and organ massage 3 times a week, and takes a bucket full of supplements and Chinese herbs. But she was tested positive for the ROS mutation back about 2.5 years ago. So we have that to fall back on if her cancer does grow back.
And for our new members, this is Natalie's situation is very similar to yours, and she's doing really well now. So, you all have to always think positive. There's a lot of great things happening right now. What? Yes, she does. Yeah. She loves to talk to other patients too. So, we could, and if you're interested in talking to somebody your own age, she's got little kids, and we can make that happen.
Joyce, do you want to talk?
Hi, my name is Joyce. I was diagnosed in December of 2011 with non-small cell lung cancer, 3B, inoperable adenocarcinoma. And I responded very well to concurrent radiation and chemo. I was doing carboplatin and, I forget now.
Taxol?
Anyway, I came out of that clear. Instead of going on Alimta maintenance, which my oncologist wanted me to do, I chose to go into a clinical trial for Lucanix, and did that for 6 months until I showed progression. At that point, I was re-diagnosed. The tissue tested seemed to be neuroendocrine, large cell neuroendocrine carcinoma. And I went back into chemo, and this time it was, this is what you call chemo brain. Alimta, and if it's not carboplatin, it's something else.
Cisplatin.
Huh?
Cisplatin.
Oh no, cisplatin was the first time. This time it was carboplatin.
Okay.
Okay. The scan seemed to be stable. Some things had grown, some things indicated shrinkage. And my oncologist suggested going on kind of a maintenance thing. But meanwhile, back in December, when I had a biopsy at St. Mary's, on the spur of the moment, right before Christmas, I called the pathology lab and asked the pathologist to send that tissue to Foundation Medicine in Boston. And they do kind of a genomic assay, I think. They kind of test your tissue against all kinds of different substances, every chemo known for every kind of cancer, as well as, I think, household substances, so dishwashing detergent or molasses or whatever. And interestingly, it showed that I had a very good friend in a type of chemo that was mostly used for renal cell cancer, liver cancer. I'm not remembering the name of the family, but it's a different pathway. It's recently been approved for breast cancer. It's not been approved for lung cancer. And that causes some problems in that my insurance isn't going to pay for. I'm taking something called Afinitor, which isn't the exact one recommended by Boston Med, but it's in the same family, and it actually is the one that's got a little more research behind it. And I've been taking that for about 3 weeks now. It's 1 tablet a day, and I don't really feel too many side effects, but it was scary going online and seeing the side effects for this particular chemo agent. It's like, instead of having side effects that affect 2 or 0.5% of the people who take it. It's like 86% of the people who take this get horrible, horrible side effects. Huh. And it's like, oh, well, I'm still going to try it, because it was either that or going back on Olympta maintenance or something different. And I said, well, if I have this, test result from Boston Med, I don't know how I'm going to pay for it, because certainly insurance doesn't. I never really thought of that, or I chose not to think of that when I had the tissue samples sent. And I asked them to send them before the end of the year, so they had only like a week to send them, because just in case the insurance did cover it, I wanted it to be under my deductible. I got a letter from Foundation Medicine in Boston saying, you've probably heard from your insurance company by now. I haven't. They're probably refusing to pay for our test. And we just want to tell you that if you sign power of attorney, we'll fight for you if it takes 10 years. We will do whatever it takes. We'll go to court. You might get some letters once in a while. Ignore them. You might get demands for payment. Ignore them. Just sign here, and we'll find a way to get paid. I said, oh, all right. I also thought if my cancer morphed from plain adeno to a neuroendocrine large cell thing, what if it morphs again? Then perhaps this new agent, the Affinitor, won't work the next time. So why keep it in the arsenal and not try it? Of course, my oncologist is going a little bit nuts, saying, you just want to roll the dice. There's no research. There's absolutely no studies. There's no information about there's going to be side effects. There's going to, I don't care. I want to see what happens, because I probably won't do that test again. And that's what I'm doing. So I feel great. The only problem I've had throughout this, I've never had any bad symptoms from the cancer. I have another problem with rheumatoid arthritis, and that makes it tough, because when I'm doing clinical trials, I can't take my RA meds. And that's kind of a drag, but this particular round of Affinitor is going to go for 2 months, and then I'm going to get scanned again. And the only reason I'm able to do it is because my oncologist found samples of Affinitor that last 2 months. And meanwhile, I'm applying to the company for the 2 different dosages that they have for this on a compassionate use basis. And we'll see what happens with that. And that's all I have to say.
Well,
thanks.
Good for you. That's great.
So kind of what Joyce is talking about is what Dr. Billlings is going to talk about tonight, right, with the next-gen sequencing and so on and so forth. But before we do that, DM, do you want to talk? I saw you sneak in. Real quick.
DM's like our poster child for stage 4 lung cancer.
Yeah.
And she hates to talk.
Hi, everyone. My name is DM, and I was diagnosed in 2009 with stage 3B adenocarcinoma. Needless to say, I was shocked. My family was shocked. But on the positive, I have a genetic, or my tumor had a mutation, so I was a candidate to taking Tarceva, and luckily that's been working for me. So that's it. Thanks.
Since 2009.
Yeah.
And then just a couple of online. Emily Taylor's online. She says hello to everyone.
Hi, MK.
Kathy Parker. She's sending good healing thoughts to
Kathy.
Carrie. Okay, so, and Kathy's question about T790, it's a cheek swab. So to answer that question for Kathy. Penelope's also on the phone, and all of you who have been coming since Penelope's been coming, which is for almost a year now, she had her baby. So that's why she's not here tonight.
Little girl.
Yes. Mom is on daily radiation, weekly Taxotere, and baby Michaela arrived on 5/3, and they're still waiting for Hannah to have her baby.
Oh
Yes.
my gosh.
Yes.
2 sisters were supposed to have their babies a week apart.
Yeah.
And now it's been 3 weeks, right?
Yeah. She says she's very happy to be online. So without further ado, I'm going to introduce Dr. Billlings. We are, like I said, beyond grateful to have him here. He is not only a physician, but he's a lecturer, researcher, professor, and a consultant on genetic information. So with that, I'm going to say hello and welcome. And what we're going to do is kind of start off the same way we did with Dr. Kamich when he was here, which was so fun. And just ask you to maybe just give a definition of what is next generation sequencing.
So let me, before I launch into my life's work, really, I want to say 2 things. One, I want to introduce my colleague and friend, Alyssa Levin, who is the director of our clinical support services at Life Technologies, where I'm the chief medical officer. But she is also one of the best genetic counselors in the country and enormously experienced and capable. So you have another resource in the room besides me, at least tonight. So that's a good thing, and I'm happy for her to be here. The other thing I wanted to say before I launch into this is that I am profoundly grateful and honored to be here. And the stories that I've just heard little pieces of, are so amazing and meaningful, and I just don't quite know what to say, but I do feel deeply honored to be amongst you. And if there's anything I can do with the little that I know, I'd be more than happy to share it with you at any time. I also want to say at the beginning that I'm an internist and a geneticist. My training, I've taken care of a lot of people with cancer in my life as an internist. I trained up in Seattle, where the Fred Hutchinson Center is, and where much of groundbreaking therapies have been developed at the University of Washington and in that whole Virginia Mason, Swedish Hospital, University of Washington complex. So I've had a lot of training, but I'm not an oncologist. And so at some point, if you ask me too many questions about the drugs, you'll reach past what I know. But I do know a lot about the research approaches to cancer. I have a PhD in immunology as well. And so, and I studied a lot about tumor rejection during my PhD in lab days. So I know a little bit about cancer and a lot about research. So the question is, what's next generation sequencing? So we're about 60 years into knowing that DNA, the nucleic acids, were the stuff that genes were made of. That was Watson and Crick. It was around 1950, 1952, and when they published their little article in Nature magazine. And that set off this huge revolution, because we sort of knew that genetics had something to do with cancer already. I mean, when I went to medical school, the active debate was most cancer caused by genetics, by viruses, or by radiation or other toxic things? And we had good examples in medical school of each one. We could show that if you infected a cell with a certain kind of virus, it looked like a tumor cell. We could show that if you put vinyl chloride in the solution around certain kinds of cells, that those cells became cancerous. And it really took Harold Varmus and Mike Bishop to kind of bring that all together and say that there were these genes, these so-called oncogenes, that either came in with the virus or somehow got hit by the chemicals or radiation and were residing in our cells normally, and that when something went wrong with their control or they became mutated, cancer was induced. And Harold Varmus is now the head of the National Cancer Institute. Mike Bishop used to be the chancellor at UCSF. So distinguished groups. So, but we all knew that genetics, so the sequence, the genes had something to do with it. And so we needed to develop methods to analyze the genes. And the first generation of sequencing the gene, which is the ultimate analysis, it's the real alphabet of each one of those genes, the actual makeup of the nucleic acid sequence in each one of those. There was a so-called first generation analysis or sequencing. And there were two groups. Fred Sanger did that, and that's why most of the time it's called Sanger sequencing, because he invented it. And then Alan Maxam and Wally Gilbert at Harvard, and Alan Maxam was a colleague of mine, they invented a similar method. And this allowed in the 60s and 70s and 80s for genes to be sequenced. The methods were very slow, pretty costly, and difficult to apply outside a small set of genes. So they weren't that useful for researchers or clinically for cancer work. They were enormously useful, for instance, in HIV. Almost all that we know about HIV, and in some sense the cancers that people with HIV get, come in part from the use of these older sequencing techniques in the study of the AIDS illness. But when the Genome Project was conceived of in the late 1980s and then funded initially, it became pretty clear that the sequencing technology that we had was not going to do it. The Sanger or Gilbert methods were just not going to do it. We needed new ways to analyze genes in mass, because we're going to look at 20 or 30,000 human genes, 3 billion individual bases of DNA. And if we'd used Sanger methodology, it would have taken us 100 years and would have more than bankrupted the US Treasury. So a variety of very enterprising technologists. Craig Venter was one of them. Francis Collins, the current head of NIH, was one of them. Variety of people started experimenting around, and out came next generation sequencing. And that was a completely different way of analyzing the bases of DNA in a cell. And it involved cutting up the DNA into small pieces, analyzing parts of those small pieces, using a computer, and kind of using the computer to reconstruct the long string, the 3 billion base pair string, from little pieces. And so next generation and there have been several sub-generations of next generation sequencing, including methods that my company, Life Technology, has introduced, methods that another company, Illumina, has introduced, and a variety of others, as a matter of fact. There are several competing next generation technologies. But the answer was that we were able to do what was taking, with the Sanger, the original sequencing method, months and years and lots of money, we now can do in minutes or hours and for much, much less money. So the Human Genome Project, the price tag was $3 billion. And we didn't even really get a complete human gene sequence from the first iteration of the human. We got a kind of a draft. We now are sequencing whole human genomes for $10,000, and it's still going down, the cost of those sequences, the actual running of the machine and the reagents. It's about $10,000. And we can do it in a few days. So what took 10 years and 3 billion now is a few days and $1,000, something like that. Between $1,000 and $10,000. And so that's the kind of amazing technical progress. Now that doesn't mean we understand everything that we sequence, and that we don't need to confirm it. We don't need to do a lot of clinical research on the information that we find, whether they be a genome from a cancer cell or a genome from a nearby normal cell. And I've engaged in lots of different research projects looking at cancer cells and neighboring normal cells and trying to understand the differences. And there are many. And a lot of the stories here tonight about, well, we thought it was one sort of cancer, and then we treated for a while, and then we looked at it again, and oh, there's another, seems to be another kind of cancer there. Well, we're not entirely sure whether there weren't two at the beginning. But what it also tells you is that by looking in the classic way under a microscope, you can get fooled. And what we're talking about here is taking the DNA from a large amount of your cancer and analyzing it and finding all the mutations, finding everything that could be acted upon, and using that as the basis for treatment planning going forward. And that's a whole different way of approaching it. We have to prove through more research that that's a better way. But I'm, given the number of drugs that are being developed for specific mutations in the cancer genome that are different, that are not present, or not activated, or not rearranged in the normal genome, I think that there's lots of room for optimism and hope that next generation sequencing will provide some important new avenues for people with the illnesses that you have.
Can you give a couple of examples of patients that you've seen and studied? And
sure. So most of my hands-on experience has actually been, well, two different things. Most of my hands-on experience has been with breast cancer, not with lung cancer, but the model is the same. So I'll tell you about a study that we completed and published towards the end of last year on breast cancer, but take it as an analogy. These were women with triple-negative breast cancer. So that would be like having lung cancer with none of the known markers, right? Breast cancer, you look for hormone receptor, you look for the HER2 expansion, the ERBB2 expansion. And if you don't have any of those, that's called triple negative. So you don't have the ER receptor, you don't have the PR receptor, you don't have the HER2 expansion. And that's a difficult to treat kind of breast cancer. You frequently give cytotoxic chemotherapy early on and radiation locally, which is similar, I think, to some of the approaches that you all have experienced. And often you get a durable response to that, but many people relapse. And quickly you end up with a situation that can be very difficult to manage. They're not responding to chemo, or they're having lots of side effects from the chemo, and you can't really radiate the field anymore. And so what we did is we took a series of 14 of those cancers, people with that kind of presentation, and sequenced their whole cancer genome. And we also sequenced their normal cells and compared the normal cells with the cancer genome. And when we found a difference, we then confirmed that difference in two ways. We applied another sequencing technique to make sure that the mutation in the cancer was what we thought it was. And we also looked at what genes were expressed in the cancer cells and asked, was that gene abnormally expressed in the cancer cells in some way that we could say was different than we would have expected in a normal cell. And when we found, so in each one of those 14 women with breast cancer of this sort, we found an array of differences. We found a lot of targets. And so we spent a lot of time with experts at some, at a molecular tumor board, which we kind of invented as we went along. And we looked down this list of differences between their tumor and their normal tissue and said, well, are there drugs to any of those changes? Is there any evidence that that might work in this kind of breast cancer? Is there any evidence that it might work in another cancer? So could we extrapolate the information? And we made choices, and we advised the patient and advised their treating physician about those inferences that we had drawn. And we found them often we even found them clinical trials of the agent that we thought might work. And there were some remarkable responses. I'm thinking of one which had quite a significant amount of tumor in her body, and she went on this this drug that would have never been thought of to be used in breast cancer. It was a drug that was used in melanoma and in other cancers. But we found a mutation that made us believe that it might be useful in this particular. She got a very long, several years of very significant response to that. Now, as with many of these stories, she developed some resistance over time to that particular thing, but it gave her several more years of high quality life. There was very little toxicity to that. She got it on actually on a phase 1 trial, so she didn't have to pay for it. It was a remarkably positive turn of events for her. We are hearing increasingly of people with non-small cell lung cancer getting their tumor sequenced by Foundation Medicine or other laboratories that offer that kind of sequence-based. And what they're finding is some of the targets that you've already heard about, KRAS, EGFR, ALK, ROS, the big ones where there's good evidence and good clinical trials that those agents are active in subtypes or subpopulations of people with non-small cell lung cancer. But we're also finding some of these other markers. They're not that many yet. A lot of them are in late-stage clinical trials, but we're finding markers that we didn't expect in non-small cell lung cancer that are present. Now, we don't know that the agents that work on those markers, work on those mutations, will be active in non-small cell lung cancer. We don't know that. But we do know the toxicities of those agents. We do know their safety profile, at least in the patients in which they were indicated, where they were approved. And so while we don't know its effectiveness, we know something about its safety. And so I think what we're going to see with the increasing amount of sequencing of tumors, whether they be lung cancer tumors or colon cancer tumors or pancreatic tumors, is increasing amount of off-label use of approved drugs in cancer. And particularly when a biomarker, a genetic mutation, indicates that there might be activity or involvement of the pathway that drug targets. And what I'm working very hard now on with some colleagues is to improve the environment by which people can receive off-label medication and have it paid for by their insurers. I think we can, it's difficult, obviously, to make that argument. We haven't proved effectiveness, but I think if we help the insurer find a way to prove that it's effective in an individual case, they will pay. And I think we can create that environment, and I'm working very hard to use technology to help insurers get past that decision and help people with off-label use of approved medications.
Are you talking about other ways other than clinical trials to prove that?
I'm talking about situations where a person has a tumor, has a marker that there is an off-label agent for, and I'm trying to get the insurers to agree on a monitor, a surrogate monitor, essentially, of disease activity. Might be a PET scan result, might be circulating DNA or circulating tumor cell with the mutation that we're interested in. And really, I'm trying to get them to agree to cover a couple of rounds of an off-label use. And then if the trend is down with the surrogate marker, they would continue to pay. If there's no response or there's significant toxicity or the patient wants to come off, they would be off the hook for paying for that. But it's using sensitive, it's getting them to agree on the front end that if there is a sensitive monitor, that they will respond, will continue to pay if the monitor is favorably impacted. That's what I call really a scientific basis for coverage decisions. And that's what it lacks. I mean, coverage decisions, you know, I've been in this business long enough to know that coverage decisions are complicated, not always based on technology assessments, but based on all sorts of other things, the cost of medications, the political environment, all sorts of things. And one drug company makes one decision, or one insurer makes one decision, another makes another. CMS does something else.
Right.
So I'm trying to give them a real scientific basis for making a small, I mean, this isn't going to solve all the problems, but it's one set of problems which is becoming more important, and where we might provide some advantage.
Dr. Billlings, what role, if any, do you see the patient having in that process, in helping to move that process along?
So there are two kinds of roles. One is enrolling in clinical trials, because we don't, in many cases, in many kinds of tumors, we don't actually have what I would call adequately sensitive monitors for my model. So I think participating in research as much as you can has to be fundamental. I think talking about, you know, I mean, I've had illnesses in my family, both my parents are dead. I know how hard it sometimes is to advocate for yourself or talk about your experiences. It's wonderful that you all come here and have a kind of a forum, a nurturing, warm forum by which you can talk about and share information. It's so important that you share information broadly with the research community, with your fellow patients who need your support, and tell your stories. Because first of all, as my colleague Ronnie Andrews is apt to say, you tell your story and you tell it loud enough, people start to pay attention. So Ronnie likes to talk about, you know, his wife going to bat, and we have many people in our company who go to bat for people with illnesses. And, you know, who there are examples where Ronnie's wife has, someone's taken a drug, paid for it out of their pocket, got a response, and she's taken those bills and, you know, went to their insurer and basically demanded that they pay her back, this person back, for all that money they've invested in, because they're obviously got a response. They're you know, their disease has responded. They've gotten a remission or even a cure. So I think advocating for yourself and advocating for your neighbors and your community members who are afflicted with the same illness, incredibly important. And, you know, politicians and insurers do respond to success stories. They do. And they don't like being embarrassed and being pointed at and told, you know, you're neglecting this.
And they're more responsive listening to patients.
Absolutely.
Than they are listening to a for-profit company. Because our only vested interest is your survival. And for-profit companies, you know, have to please their investors,
shareholders,
you know, and their shareholders as well. So it's really, really huge to advocate for yourself.
I think it's enormously important.
I was just at the SWOG meeting, the Southwest Oncology meeting. I'm the advocate for lung cancer there. And I have to say, I really came away energized, because this year there were so many, just to what Dr. Billlings is talking about. You know, I was hearing about lung cancer patients with the HER2 gene, the HER2 marker. That's huge for breast cancer. You know, things are happening, and adding Herceptin to a clinical trial of maybe carboplatin Taxol or Alimta and Herceptin. That wasn't the only one. There were other things happening. Clinical trials with drugs that are working in other cancers. So, you know, for the first time, I really felt really encouraged about what I was hearing to what Dr. Billlings is talking about. Things are happening.
And I think I'm about to ask, Emily online has a question, and I'm going to put a second part to this because I think this is where she's going with it. But she wants to know how exactly this technology and this sequencing is going to help cancer patients? Is it, is it just the dangling carrot, like, oh great, we found that you're a lung cancer patient and you tested positive for some renal cell thing, but we can't get you the drug? I mean, what does this exactly mean for lung cancer patients?
Right. So if you sequence the lung cancer genome, you will, the way I envision this will work is that the first will come out will be the relatively short list of well-proven, randomized prospective clinical trial, FDA-approved, CMS-covered targets. And, those are, it's a relatively small number. It's like between 5 and 10 is the number. And those, whether you have the mutation which is conducive to responding to those medications, and maybe you'll also find there are some metabolic mutations which make you more likely to have side effects or metabolize the drug in a slightly different way. You'll find those. That will be the first wave. The second thing will happen, you'll find a set of mutations in your cancer which are common in other kinds of cancer and where there's a drug in those other, approved drug in those other cancer. Take BRAF in melanoma. That's the kind of poster child, right? A year or so ago, there were these amazing pictures of people who had melanoma throughout their bodies. And they went on this BRAF drug and it just melted away. And unfortunately, as Gina Colada reported in the New York Times, there's sadly stories where most of those people relapse after 6 to 12 months because they've developed some sort of resistance to the BRAF drug. But that doesn't mean that they didn't get a remarkable tumor lysis, tumor-killing response. So we're going to find whether those mutations exist in your lung cancer. And if you fail the standard therapies and the targeted therapies that are approved in lung cancer, then the next step in my mind would be to try the approved drugs from another cancer which have a mutation in your cancer. So that would be the next set of experiments. And then if you get a response or don't get a response or relapse, then we'll look at the rest of your genome for any indication of another treatable target. Forget about whether it was ever been used and approved in another cancer. We'll go even wider. We'll cast a much wider net. So that, for instance, maybe we'll start using seizure medications as part of a combination for lung cancer. Or, I mean, you pick or obviously immune genes which are involved in the immune response, immune modulators, along with other kinds of forms of cancer treatment. So we're gonna use all the information that's present in the genome, and there's a lot of information present in the genome, to try to give us because it has at least a theoretical model by which we can. It's not just random, going through the forest and looking for berries. It has a sensible hypothesis, a theory by which it might work because it's mutated in the cancer genome or abnormal cancer genome. Maybe it's normal in your normal cells, and we have the sequence. We're able to find that. So that's how I envision that kind of working.
So I think that sort of answers the question of when would be the right time to have the sequencing done. Obviously, first and foremost, upon diagnosis, have the molecular testing done on a lung panel, right? A known lung panel where there's targeted agents against the markers. And then if you have a marker, go on the targeted therapy. If not, standard chemotherapy.
Right.
And then once you start progressing, maybe that's the time to rebiopsy and send off for a next-gen sequencing.
Right. And we're trying very hard, of course, to, sometimes there's no, the original excision takes all the tumor, and but you have metastasis. Mm-hmm. So yes, you could go and sample the metastasis if it's accessible. We're trying to see whether you could actually just use a blood test a so-called blood biopsy, whether it's the DNA, the nucleic acid in circulating that the tumor has let go with treatment, or there are cells that may become part of the metastasis, which are in the blood being transported around. We can grab some of those cells and look at them and use them as a kind of a surrogate. Do genetic analysis, do a complete genetic analysis on them, compare that with normal cells, but use it as a kind of a surrogate of what the tumor is doing now. And I envision a time that's a little bit like what we do with people with like hepatitis or HIV. We sample their blood frequently, and we adjust the treatment to the molecular spectrum in the blood, and that will turn many of these cancers into the kind of chronic diseases that people have with hepatitis and HIV. And that's the model. Now, cancer is a tricky beast, and the number of mutations is breathtakingly large. And we don't understand all the pathways. We don't understand all the non-genetic stuff that might, non-classic genetic stuff that might be going on. But it's moving along very, very quickly.
That was going to be my next question, because with technology and, being able to put information into data and have that, the data sequenced,
right.
It's moving a lot quicker now than it ever was, right?
So we actually, we went so far as to spend a lot of money to get a data set, to really, it was a data company. All it was is it took data and collated it, and did kind of experiments, they call them in silico, where they were saying, well, lung cancer, what does all the data say about what are the most important genes that are dysregulated in lung cancer? And the movement now is to create bigger and bigger data sets for different kinds of cancers, and to look at those molecular evidence and collate it with clinical response, and to try to refine our predictions about what people who are at risk for cancer, what their real risk for actually developing a tumor is, and what drug works best in them.
Because you think you know it all, and you've studied one patient and you have all of this data, and then you take another test 6 months later and you have new data because the cancer's changed, correct?
Right.
So
chemotherapy, progression, changing your immune system, those all seem to affect what happens to the tumor. It changes the tumor, which was one configuration, one set of mutations at the time of diagnosis. Later on can be quite different, histologically different. You can have we've heard some stories already tonight. Thought it was adeno, now it's neuroendocrine. Well, think about that on the molecular. You might have this set of mutations at the time of diagnosis. Now later on, after treatment, and you've killed the 90% of the cells and only the hardiest 20% come out, it has a different genetic configuration. We need to be able to sample it and respond with treatments that are tailored to the status of that patient. Where this whole personalized medicine or precision medicine, or whatever you want to say, that's exactly what we're trying to do. We're trying to respond to illness over time, and specifically.
One of the studies that was coming out of SWOG, or being approved at SWOG a few weeks ago, was doing something completely different than ever has been done before, and that was looking for more markers at one time, and more more drugs at one time.
Right.
Instead of doing it the old way, a 3-year trial, you're only looking at this one marker in this one cohort, now looking for multiple things at once. So
and I think that's enormous. I mean, we've learned again, in part from studying other illnesses, is that we often have to have targeted treatments for a variety of pathways at the same time to really knock out those cells. And that's why so we analyze a big piece of your tumor, we find all the pathways, and we hit it with 2 or 3 different kinds of, that's what they do for instance, hepatitis C treatment, many different pathways. And I think that's what we're going to do in cancer too. We're going to try We're going to try individual agents. We're going to see that many cancers escape after responding to individual agents. So we'll give them 2 or 3 at the same time. That won't allow much escape. And I think we're going to see that kind of combination approach.
So going back to, for a second, to the cancer changing, and we know that it changes.
Yep.
What does that mean, you know, to not only this roomful and the people online and anybody else who might watch this later, who's living with cancer every day? I mean, you know, how do they know when to talk to their doctor about possible rebiopsy? How do they get, you know, their doctors to agree to rebiopsy?
Yeah.
How do, you know, I mean, it's
that's a tough discussion.
It is, and you know, I know that I, you know, am more than willing and do frequently tell patients to talk to their physicians about rebiopsy, especially after they've been on a certain therapy for however long and there's progression and whatnot. And when they get pushback, my first suggestion is to always get a second opinion with someone that, you know, I know will help them through that process. But people who don't have access to us and our foundation, like, what is the
well,
what
I
can
think
patients do?
I think getting as informed as you can as a patient, whether it's this foundation or the Cancer Society or other online or even Wikipedia, whatever you read, and when you see something that says people who are on your treatment who then have failed or got a side effect or had to go off or didn't get a full course, what happens to them? Grab that article or grab that reference and bring it to your doctor and say, look, this sounds like me, what do I do next? You know, what makes sense to do next? So I think you have to, and you know, you'll find, like with everyone, oncologists, there are a range of personalities and styles. Some are more nurturing, some are very aggressive, some have, you know, some are way, you know, are very experienced, some are just out of their training. You'll find a kind of a range, and you have to find an oncologist whose temperament and style meets your expectations. And if you're not getting it, you know, it's your skin in the game, it's your illness. You got to advocate for yourself, and if they're not doing what they need to do, obviously you can find help in a room like this, but you really need to find a doctor who will do what you want.
And you also have to, you know, we hear so often patients will say, well, you know, I really like my doctor and I don't want to hurt his or her feelings. And you just have to ask yourself, what would I do if this were my child?
Right.
And you know you would move mountains. So you have to value yourself equally as much as you value your child.
Right. So there's one other thing. So one of the things we do is make the equipment help Foundation Medicine and other companies like and labs like that are doing, you know, at the Hutch or at the Dana-Farber or up here at UCSF or at Stanford, do these kinds of genomic analyses. But we're also using genetic technology to help subtype tumors. I mean, and I just wanted to mention that briefly too. One of the conundrums in early stage lung cancer is who actually is cured when they get just a surgical excision, and who needs chemotherapy, adjunctive chemotherapy, in early stage cancer, stage 1 and stage 2. And it's pretty clear, because it's been hard to demonstrate effectiveness of chemotherapy, certainly in stage 1. And even in stage 2, it's not clear how many patients benefit. It's probably a subset of people with those early stage tumors who get the most benefit from chemotherapy. And I'm talking about you know, doxycycline and, you know, those kinds of drugs. And we're developing and have actually already put it into our laboratory a test that helps differentiate the high risk early stage lung cancer from the lower risk. And with that information and the staging information and the surgeon's input and the pathologist's input, we hope that we can demonstrate that the people at higher risk would benefit the most from chemotherapy. And we actually have launched a prospective randomized trial to show that the people with the higher risk tumors benefit from adjunctive chemotherapy, because that would then allow the lower risk people maybe to avoid the toxicity of those chemotherapy, all the expense and trials and all that stuff. So we're trying to help subtype early stage tumors using genetic information. It's a different kind of test. It's called an expression test, but the principle is the same: finding subclasses of tumor which are responsive to chemotherapy, others that can be cured simply with surgery.
One of the questions online from Stephanie, and I think other than we had talked about T790 in the study to look at it as potentially being a germline mutation, she's asking, will this technology and the next generation sequencing ultimately help with possibly finding other potential germline mutations?
Absolutely.
And thereby getting your children or family members tested?
I mean, one of the interesting, we don't yet know, for instance, there are all sorts of really interesting questions. How many germline mutations, if we take just lung cancer, how many are there that predispose people to lung cancer? Adeno, all the different kinds. There are probably many genes in our genome. I can't speculate how many, but there are probably many that have something to do with risk for developing those kinds of lung cancer. Then there are questions like, if you have that risk, how big is your risk, right? We've just, the whole Angela Jolie story told you about how that some women with BRCA mutations may have an 80% lifetime risk of developing lung cancer. But people often forget that every woman has about a 10% risk of developing breast cancer. So that's the lifetime average risk in the United States. So Angela Jolie might have been 8 times higher, but there are probably people with BRCA mutations that are only 4 times higher. How do we assign a risk to that? And then what do we do to monitor? I mean, your story is we don't really know how to monitor you yet. What's the most effective way? There are examples of hereditary forms of, let's say, colon cancer, in which some people elect to be monitored with either imaging or endoscopy. Other people say, geez, I want the whole thing out right now. Just take my colon out, because what if we miss? Or what if I what if I miss my appointment and lo and behold, there was the cancer? So we need more, right, I know.
A little trickier with lungs.
Out, can we?
No, unfortunately that's not we have other restrictions in lung cancer, but so we need more studies with people who have identified that risk early in their life, where we can follow and decide what kinds of monitoring, what kinds of surveillance, if you like. And we can learn something from analogy to other cancers where there are previous experience with hereditary risk, but we'll also need to study specifically the risks for people to develop lung cancer. This is one, there'll be others. And there's nothing short of doing those experiments, but otherwise we're practicing the art of medicine, and it's better than nothing, because it's hopefully a informed patient and a concerned physician developing that artful approach. But I'd rather have data. I'd rather have it to be data-driven and quantifiable than simply the art of medicine.
I'm going to ask you a tough question. For 45 years, the survival rate for lung cancer has been 15% and change.
Yep.
What do you see happening to that survival rate in the next 10 years?
So the overall survival rate, I think, is a component of the fact that we've heard the story in this room a bunch of times, which is that we're diagnosing lung cancer too late. We don't know those people who have hereditary, who are born probably with hereditary predisposition to it, so we don't survey them, and we don't have a chest X-ray, CT scan, some sort of surveillance program. When This is a story. When I graduated and finished my training, I went to work for the federal government. I was a VA doctor.
I think I know where you're going to go.
And as part of entering the VA, you had to have a chest. You had to have a chest X-ray.
Yeah.
And you know, the dirty little secret is they found a lot of cancers back then with that program. Now they probably, you know, the argument was the radiation also a risk? But there are other countries, as you know, that are more aggressive with screening with chest imaging, and they find cancers earlier, and their outcomes are better than ours.
Right.
So the rate is lower. So I think that what I think is going to happen is two things. Subsets of people with advanced disease will either with specific drugs or with combinations will get remarkable responses. We will, in the next 5 to 10 years, find subsets of lung cancer and all the other major cancers, which combinations of targeted therapy provide durable, long-term, major responses and cures. And I think the other area that we're going to make major advances is that we'll identify a lot of risk factors. We'll figure out how to monitor those patients, and those patients will be diagnosed and cured with surgery. So I would expect, and I'll go out on the limb, I would expect if we say it's 17% now, I would say in 5 years it'll be 30%. And in 10 years, I think most of lung cancer and most of all the major cancers will be chronic, manageable diseases.
That's pretty good news, huh? Yeah.
That's my guess.
Yeah.
Things are happening sort of fast and furious right now, right? I mean, especially when we look at all the things that are happening in lung cancer, and this sort of the technology and the testing is going to play a huge role in treating cancers across the board moving forward. And like you said, Dr. Billlings, when you compared it to HIV earlier, right? It's going to be a matter of finding that cocktail, right?
You know, maybe, I mean, I don't know how many of you have had a personal experience with HIV, but when I came to San Francisco in 1990, I was practicing in the city, and that was at the height of really we had 1 or 2 drugs that were active in HIV, and everyone was dying of pneumocystis and all or Kaposi's sarcoma, which is a cancer that the HIV patients would get. It was a mess. And they were all dying. You know, the average life expectancy in 1990 for HIV was 2.5 years, something like that. Mm-hmm. Now, the data is if you're diagnosed with HIV today, your life expectancy is as good as an unaffected person of the same age. And in fact, because you get better medical care, you actually probably have a slightly better life expectancy than a matched cohort without the virus. And that just shows you how powerful, if you get it right, and you get a few active agents and you figure out how to put them together and you test and you monitor carefully, how incredible the technology can benefit people. So and you've got people working every day trying to turn that kind of powerful technology onto the disorders like the ones that many of you have in this room.
Which is one of the reasons, that clinical trials are so important.
So important.
So important.
Absolutely essential.
Clinical trials really can be a lifeline. Is it conceivable that 10 years from now, cancer will be treated as cancer rather than the organ that it's in?
Right. That's so important. I mean, I'll refer back to the stories that some of you said. Your cancer changes over time, or they went in once and they called it one thing, and then they went in again and they called it histologically. When they looked under the microscope, it looked different. Or it's a mix of squamous and adeno. That's 5-10% of cancers have that, can't be subtyped accurately by the squamous adeno differentiation. While I think that information will always have some role in the treatment, I think it's going to be largely, over the next 10 years, largely supplanted by the molecular analysis of your tumor. They're going to get as much of it out as they can with the diagnosis. They're going to put it all in a vat. We're going to look at the genes in there, There might be one kind of gene, there might be 2 copies, which we each have, with 2 copies of every gene. Maybe there are 3 or 4 different kinds of variations, and there means the tumor was mixed. We're going to look at those, we're going to design treatments based on that information, and we're going to treat you based on that, not on some pathologist. And I can say this, by the way, because I'm colorblind. So I was never going to be a histopathologist anyway, even though I have lots of pathologists in my family. But I was never going to do that because I couldn't see the red and the green under the microscope. And that's why I like genes. Because they're easier to identify for me than
I think, so go ahead, Addario, you have a question? Yeah, you need to grab a mic. Of course you're allowed to ask a question.
Thanks. So all of this is really exciting when you talk about all these genetic markers and the targeted drugs, and you talk about remarkable responses. Is it fair to say, though, that when a remarkable response is defined as a few years or 6 months to 12 months, that's not enough, and that's not the solution? And then if we say that, then what's being done about resistance or sort of the roadblocks that you mentioned with these cases?
Sure. So I look. I don't. There's huge debates about what a response is. And the health economists say it's quality life years, how much you spend on it, and other people point at the fact that you're only getting a 3 or 6 month. And actually, if everyone dies in 2 months, 3 to 6 months is a sort of remarkable response. So it's all in the eye of the beholder, frankly, a lot of that. But look, what I want to see is what we've seen in HIV, which is real long-term cures or stable, manageable chronic illness for years, right? I mean, I hate to bring up celebrity instances, but we're watching Magic Johnson on the TV almost every night. The guy's got HIV. He's had HIV for 15 years now, something like that. And he's out there in the world doing fine. So that's what we're trying, that's the goal. And all the same issues. HIV gets resistant after time too, right? We figured out combinations to deal with that. And so that's the goal with your kind of cancer and other kinds of cancers. And I don't really see why it can't be true. We don't have all the agents together yet. We need more targeted agents. And as I said, we need probably a blood-based monitor of disease activity that's accurate. But when we have those two in hands, and I'm convinced we will have more targeted treatments and a good monitor, we're there as far as I'm concerned. We're going to get there very, very quickly when those are in hand. And because I guess I have, I've been a physician now since 1979, and there are so many good people working on these problems wholeheartedly, whether they be in academic situations, in foundations, in companies like mine, working so hard to come up with this kind of improvement. So I guess I just feel like if we apply ourselves like that, good stuff will happen, and you have reason to be hopeful.
To Dr. Billings' point tonight, he said many times how important you all are in the process. And I think you need to leave here tonight knowing that you're part of the solution.
Right.
You have the solution in your genome. It's there. And my personal goal is to get companies like Life Technologies and pharma, et cetera, when they come up with a new drug, and it's on the front page of the Wall Street Journal, that there's a big shout out to all the patients that made that happen. Yeah. Because without clinical trials, it doesn't happen.
And I think to Addar's point and what she was saying is I think sort of as a general rule in talking with patients all the time, and it's common. It's like, what do you mean you're going to tell me this study that you just spent X amount of money on, and you've got this thing, and you're gonna maybe give me 2 extra months. Like, what are we even doing here for 2 months, right? And it's a struggle with lung cancer patients because of the lack of progress over the last going on 50 years. But the good news right now is with industry, be it technology or pharma, or, biotech, patients, foundations, all coming and working together, that ball is rolling, and it's rolling at a fast pace. I mean, nobody 5 or 10 years ago would have said, in 5 or 10 years, X is my guess. I mean, nobody would have said it. And I know I've said it to this group before, and we're getting ready to go back to ASCO again here in about a week and a half, but 3 years ago, you'd walk through ASCO, and hardly anybody had anything going on in lung.
Right.
Last year, there was hardly anybody that didn't have something going on in lung. So it's happening.
Let me give you one more example. And this is, again, an example by analogy. It's not, about lung cancer. But when I got my PhD, which was around 1980, to do a sequence required a room, literally a room maybe half the size of this room, full of machinery. And even as at the end of the Genome Project, so the Genome Project started around 1990, it was over around 2001, the standard machine by which we analyze DNA took up a huge piece of real estate. It was hot, and it required all sorts of pipes and electricity and all sorts of stuff. This is the sequencer that we manufacture. This is a gene sequencer right here, this transistor chip. And this chip, with the blood put on one end and the reagents circulated around it, this is the chip that will do your whole genome sequence very accurately in a few hours. And the machine that actually analyzes it and sort of pumps the stuff, it's the size of a IBM typewriter. Fits on that thing. So just think about size, cost, speed, that this kind of, and this is real. This is happening. The people all over the world are using the machine that uses this chip to sequence DNA. So, and that's just in the last 10 years. That's the kind of technological advance we've seen. So this is unleashing human creativity, human will to make disease management and understanding of disease. This is unleashing forces that we've never seen in this world. And we focus this stuff on understanding and science and clinical trials and sharing amongst people. We're going to get to places we never dreamed we ever could get to very quickly.
And I think to that point about technology, lung cancer patients have a very unique set of circumstances given that their cancer is in a vital organ, right? So something as simple as, or what might be simple, deemed simple as a biopsy on breast tissue, it's like, oh, you go in, you get what you need, right? On your organ, it's your lungs, it's a bigger deal. But because technology is also advancing there, and we've talked about it here in the living room in the past with some of the new bronchoscopy equipment that can get to areas of the lung that you weren't able to get to before, and you can get good quality tissue to run against the technology that Life Tech has. I mean, it's happening, and it's about, going back to what Dr. Billlings said, again, it's about patients being informed, being educated on their options, finding resources like ours and others who can get you access to that information, access to the physicians that can perform the procedures so that you can go into your treatment with the most information possible, right? I mean, that's just kind of where
Exactly.
Yeah.
Highly informed treatment decisions that are patient empowered.
Yeah.
That's where we need to be.
Does anybody else have any questions? Terry?
Terry.
Before I ask my question is I want to address what you had mentioned about just the added a couple months, and to reiterate what Danielle and Bonnie and the doctor have been talking about. My neighbor was diagnosed last year, and she was a very healthy, active 71-year-old, and then when she was diagnosed, and it took him a while. But that was the question she kept on asking me. I'd go over there, and everybody's journey is their own. But her biggest question was, well, if I do that, it's just going to add a couple more months. You know, it's just going to delay the outcome. And I tried to stress with her how important that, yeah, maybe 5 or 10 years ago, 3 months wouldn't have made a difference. But right now, the technology in all cancers, just cancer alone, with the genetic testing and stuff, 3 months is all that you need. You don't know when the blood tests are going to come. It might happen tomorrow. That's how fast it's moving. When Natalie was first diagnosed, just the momentum that it was going from 3 years ago to now. You talk to a doctor now, and they'll say something one month, and in 3 months it could be totally different because it's moving so quickly. So the key thing is this thing is going to be solved, and you just need to do. And the thing is what's sad is there's a lot of doctors out there that still, depending on your circumstances, I think with my daughter, because she was so young, there was more doctors that were, go, go, go. But I mean, at any age right now, everybody should feel that the fight is worth fighting, and that if you do what you can and you advocate for yourself, that you might buy enough time, and actually, it's not winning the lotto like it used to be. It's going to be reality soon. So you got to keep on fighting. And the one question I have for the doctor is with the genetic testing, can you tell anything with regards to, say, if it is genetic, the cancer, is there any kind of link in with the immune system are they doing any kind of correlation of how the immune system's working?
There are now targets that have been identified that are the T cells or B cells, the cells that make up our immune system. There are other cells in the immune system, but the major active cells in our immune system appear to respond to certain kinds of targets. And yes, the presence or absence of those targets allows for certain kinds of vaccines or immunotherapies to be brought to bear along with traditional chemotherapy and targeted chemotherapy, so that we can marshal the immune response as well as kill the tumor cell kind of directly with the targeted. And there are clinical trials, very active clinical trials that are doing that now. We're actually collaborating with one of the drug companies towards making one of those kinds of approaches both in melanoma and in lung cancer. But there are many. And so those are just, you can sort through clinical trials of specific agents, and you can find clinical trials in lung cancer of immunological approaches. And those are all going to come together, in my view. My suspicion is that some of the targeted agents or some of the classic chemotherapeutic agents impact the immune system and have always impacted the immune system in ways that sometimes is helpful, sometimes is not helpful. So as we get to be a little more sophisticated, we'll try to lessen the unhelpful impacts and in fact marshal the immune system to act synergistically with our targeted treatments. And that, I think, is going to be enormously effective. And actually, in particular in melanoma, I'm on the I'm on a foundation board that's involved in melanoma care. And in melanoma, there's been a lot of really creative use of immunotherapy and these targeted treatments. And they're getting, even people with very advanced melanoma, which was just awful in the old days, they're getting some really remarkable responses. Yes, I don't know that drug. I was wondering about it.
I don't remember the long name for it, but it's an immunological approach.
Yeah, I wondered from the name whether it wasn't.
So I go down to San Diego once a month for an injection, and the requirement was you had to have had one round only of chemo and or radiation, and then have had a complete response, which I did. But my oncologists, all of them, thought I was absolutely whacked for doing it because it was a double-blind, randomized trial, so that there was a very good chance I would get placebo.
Right.
And even if I didn't, I would never know if I was getting the actual vaccine or getting the placebo until this study is over. So I still don't know.
Right.
And it was only after I was, given the boot because I had progression that I thought, there's some ethical problem here. I think that they really shouldn't do that to people with advanced stage cancer. They should, I don't know, maybe I'm wrong, but.
The problem is what I said to you when I was describing my ideas about how to reform for off-label use of drugs. We don't know about the efficacy of a lot of the things that we even have quite a bit of evidence for. We don't know that, and at some point, I know you want to do what you want to do, and you want whatever can be done for you to be done. But at some point, your neighbors, the community, we all need to know that what we're doing is efficacious, that there is some, and one way to do that is to collect, and that's why I think it's so important that people who use medications off-label, for instance, they share there has to be a repository. They have to share that, and that'll be a prerequisite in my model, that they have to do that, because if you do enough anecdotes, then you get to a data set. It's not as good as a randomized prospective trial because there are biases in the data set, but it's almost as good. And it collects the information. If you just sort of do it willy-nilly on your own, it may meet your needs, but it doesn't reach the question of your neighbor, your compadres in here who want to know whether what you did was effective. And you can only tell by sharing the information and engaging in clinical research in some fashion or another. And I wish there was another way. I wish there was some, message from on high that would tell us when we're doing something that's effective and when we're not. And there are a lot of ineffective stuff. I mean, there's, in the history of medicine, so many things that we thought were working. In the old days, it was bloodletting and leeches. Right, and leeches actually work in some things, actually. Exactly. But they're very good for surgical things. But we had all sorts of crazy things. Garlic in the ear and all that stuff for brain tumors and all sorts of things. And
even with the Leucanix trial, and I think a lot of the phase 3 trials they get, and I think I was told years ago when I was first diagnosed that. Up until very recently, all of the immunological approaches were universally disappointing because they showed great promise in phase 1, great promise in phase 2, and then they couldn't reach their endpoints in phase 3. And, that's one of the reasons I said, okay, I'll do this, whether it's placebo or not. I want to follow through. And I wasn't doing anything else anyway. It was except wait and watch or go on maintenance, which really wasn't proven to be efficacious either. So I did it, but the carrot at the end of the stick was that Leucanix in the second phase, phase 2 trials, added 7.5 years of overall life expectancy, not 2 months, but 7.5 years plus. So that was like, oh my gosh.
It's a big carrot.
That's a big carrot.
Yeah.
But
well, the immune system is, we all have immune systems, and some of us have cancers with whatever immune system we have. So immune system is going to be part of the answer, in my view. It's not going to be the whole answer. We're going to have to learn how to ramp it up or ramp it down. You have rheumatoid arthritis as well as a cancer, so your immune system has its peculiarities as well. So everyone's immune system is different, as is their cancer. And that's why we need to molecularly analyze the immune system and molecularly analyze the cancer and design a treatment approach that fits both.
Quick question. Your company wants a large chunk of tissue, right, to use?
Not that. It's, we only actually need to do the genome analysis, we actually need a very small amount.
But more than a slide.
More than a slide.
So I understand there's 2 companies in Southern California that do this, they say enough tissue to show architecture. And it has to be excision surgery, excision biopsy, and then it has to be put on ice, overnighted down to Southern California. Is that?
I don't know those companies.
Okay.
But I'd be happy to look into it for you if you send me information.
Okay. Thank you.
You're welcome.
There are less and less trials now, though, that are using placebos. Most of the trials, you get a drug. You get the new trial drug, and then you get a drug that is a known drug for the particular, disease. So, those are all questions you need to ask before getting into a trial.
Right.
You have options in trials as well.
Right.
Terry?
I assume that your company is a profit company?
Absolutely.
Okay. So when it comes to, is there different rules with regards to, like say you're testing and say you were a manufacturer or researching the blood draw of trying to find cancer in blood, do you have to run a clinical trial to get people to volunteer to have their blood tested, or can you?
Well, sort of. There's that's a very, very good question, so ethically, we need to inform you and consent you, and in this country, for a variety of reasons, we also need an IRB. In most cases, we need an institutional review board to review, even if we're doing it within the company, review why we're doing this research. Does it make sense? Does the design make sense? And are we truly informing you of all the risks and that you might encounter by participating in our trial? So the answer is there are a lot of both legal and liability but just ethical and what's generally kind of comes under the umbrella of something called the common rule, which govern any entity, whether it be a corporation or a nonprofit or an academic institution, how they interact with patients, with people wanting to participate in research. And so, yes, we have to do all those things. Sometimes I think it's burdensome, frankly. I'd like to be able to bring people in and just get them to participate more willy-nilly, if you like, because it would pick up the pace and reduce the amount of paperwork. But there's reasons why that superstructure was developed. It does protect and make sure that people who participate, even in the slightest way, understand. There have been disputes over the years about who owns the results of research that might be done on your materials, on your tumor. Who owns that? It has to get cleared up at the beginning, right when you enter, so that everyone knows where the ownership pathway lies. And that's why those protections are in place.
One more question. What is the terminology? So if we were trying to look for clinical trials that were working on the immune
system?
Yeah. What are the
I think
key
you can
words?
actually, so obviously clinicaltrials.gov is where a big collection, not all of them, by the way, but a very big collection of clinical trials are. And then I believe there are keywords that you can search.
Yeah. We've just partnered with an entity called Smart Patients, and they have put together a great deal of software that really will enable you to search and really, really be able to get through clinicaltrials.gov in a much more user-friendly way.
There are a bunch of Smart Patients like me, Collaborex. There are a large number
Cancer Commons.
Cancer Commons. A large number of entities that if you contact them, they'll help you find trials that have all the characteristics that you're looking for, if they exist.
Terry, are you asking about clinical trials specific to like immunotherapy against the cancer, or clinical trials looking at just the immune system and whether or not a person might be immunosuppressed? Okay. So when it comes, we're working with BMS right now, actually, and they've got several trials going on in immuno-oncology. So I can maybe talk to you about that after.
Right.
And as far as the clinical trials, looking at to see whether or not you might have, suppression of the immune system, I can help you, but I don't know about anything going on right now. So.
When I was diagnosed with lung cancer 3 years ago, my tumor was tested for the EGFR mutation, but the entire DNA wasn't sequenced.
Right.
Are you recommending that your entire DNA be sequenced?
What I'm saying is that, that was my story about the triple-negative breast cancers. I think that everyone who has any cancer now should, at the time of diagnosis, have all the targetable, approved mutations for that cancer analyzed at the time of diagnosis, and then working with your oncologist, figure out when to apply those targeted things. Then, when if you get a full response, you're cured or you're in remission, fine, let it be. If you have a relapse or you start to progress and you've eliminated all those well evidence-based targetable, then I think you should go back, either rebiopsy. Ideally, you'd rebiopsy if you have something you can easily get at and can rebiopsy. And you can even sometimes rebiopsy a metastasis that's near the skin or somewhere more accessible than your original tumor. Or, as I hope in the next few years, we'll be able to do it right out of your blood. You should have your tumor reassessed at that time and ask what mutations are present now, after chemo, after all the years have passed, and are some of those targetable? And so that's what I'm advocating, is the whole genome analysis. If you have to do it on the original one, fine, if that's all you have. But if you can get rebiopsy, get another piece, and do the whole genome on that one, and see where you are.
When you talk about rebiopsy, when you're on chemotherapy, doesn't your tissue become necrotic?
Yes, absolutely.
So you're really kind of looking for a new.
You're looking at, yeah, right. For instance, in lung cancer, for instance, the PET scan tends to identify areas that are metabolically active, which are growing, and can be you can distinguish, kind of stuff that lights up on the PET scan with stuff that's dying. You'd obviously like to get some of that growing material when you're relapsing or progressing, and get some of that and do the whole genome sequencing on that, because that's where the current active form of your cancer really resides, and that's what we want as broad information about as we can.
But do you think it would be helpful if all cancer patients have their entire DNA sequence, and then you can make comparisons between?
Well, it would certainly help identifying both in their tumors and in their germlines, in their normal tissue, factors that predispose them. So if you took, all people with all lung cancer and looked at their tumors and what was driving their tumor, and also what's in their germline, it would help all those people who are then born, who might have been born with a risk for lung cancer. And then we could then ask questions about how to survey, how to monitor them, how to follow them up, maybe how to prevent their predisposition from manifesting itself.
And I think, DM, what Dr. Billlings is saying is that right now, probably not, like right up front, right? But somewhere down the road, the answer is more likely than not going to be yes. Like right now, look for the mutations or biomarkers that we know there's a targeted therapy for. Then when you progress, then move on to that. In the future, maybe they're going to pull the biopsy and automatically run that immediately.
The whole genome sequencing now is a little too expensive to do on everybody, frankly. And there's too much kind of unknown information in a whole genome. We get a lot of information we just don't know what to do with. Now, I think if you're kind of relapsing and, you've gone through the standard stuff, that raises the benefit for you past all those barriers, the cost barrier and and the unknown barrier, and it says, I think it could have value for you. But right now, for the standard patient, except for on a research project, and there are plenty of places, by the way, cancer institutes, everybody who gets a new diagnosis of cancer is getting their sample banked, their tumor banked, and their germline banked. They're going to do a whole genome sequence on all of them very soon. Many of them are starting to do it in a sort of a measured way because they don't have enough money to do all that sequencing, because it's still, but as I said, with these kind of technical advances, the cost and speed is going to go down, and all those repositories of people with cancer are going to get sequenced. That's going to happen.
One of the studies that Alchemy is getting ready to do, DM, which you would fit into the inclusion protocol for, of course I shouldn't say that because protocol is not written yet, but you have to be under 40, so there you go, is doing, part of the study is exactly that, looking at this young lung cancer and doing a next generation sequencing on it and looking at, you know, what might be going on there.
Different subsets of patients are really, you're going to see the most progress because we're going to type them in a different way and move them along.
And you know, just to kind of hop back for a second to the immune system, it used to be believed, I know when I was a little girl, my parents were told, you know, don't give your kids too many antibiotics because they'll become resistant to them, and then someday when they really need them, they won't work. But we know today that the body actually recovers from using a specific medicine. Let's take Tarceva, for example, or crizotinib, or carboplatin, whatever. It just a few years ago, it was believed that if you had one drug, you could never have it again once you progressed. But now we know that the immune system actually, you know, gets your body back into a position where you can take that drug again. And we see that all the time with Tarceva and crizotinib, where it gets reintroduced, maybe with another drug, and vice versa. So, I mean, that wasn't known a few years back.
So I'm getting the 2-minute warning, and I just want to put out my a couple of thank yous and announcements, and then we can continue after if anybody else has any questions for Dr. Billlings for a few minutes. But I wanted to do a huge thank you to anybody who might be watching from Chicago, who may have been at our 5K last weekend. It was absolutely amazing, and I know Emily's online, so I want to let her know about her, you know, little team NBEN that drove 3 hours up into Chicago to be there to support her in her journey with lung cancer. So. I also want to thank everybody in the LA area, especially Hank Baskett for the Hank Baskett Golf Classic. That was the same weekend as the Chicago run. And everybody who came out to support us there. Hank did a great job, and it was a really amazing day. Oh, and Miles, Emily's husband, was there. So thank you once again to MBEN. Thank you, obviously, to Genentech and Safeway for supporting the living room and making this possible. Thank you to everyone online who signed in tonight and was able to watch. The golf tournament's coming up June 10th for anybody who's interested in golfing. And the San Francisco runs in September for anybody who wants to form a team.
I'm expecting to see all of you there with a huge team.
Yeah, thank you to everyone.
Because we need to be an army of patients. My dream is to see as many patients running, walking, hobbling, doing whatever you need to do to get through our 5K run in San Francisco and see a sea of people like we see for some of the other cancers.
Here, I've got 5 seconds to thank also Life Technologies for their support of the foundation. And that's it. I just need to get it in. I kept talking.
Sorry.
Right. Oh, and next month, I think we're out of time, but just for everybody in the room and people online that I know are still watching, Smart Patients is coming next month, and I've talked to you guys about it with Gilles and Ronnie and what they've created over there, and as far as an online community for patients to learn from one another, and also, and this is where I am so technically challenged. I'm actually not as bad as you, but I am technically challenged. Where depending upon how you formulate some of the stuff that you're writing within this online community and hashtags that you use and whatnot, it will actually toss you back relevant clinical trial information. So they're really creating a tight-knit, very specific clinical trial sort of form where you'll be delivered access right into your homepage on Smart Patients about clinical trials that will be relevant to you. So it's really, really exciting. They're coming next month. So we're happy to have them. Does anybody else have anything they want to ask Dr. Billlings before? Oh, and the good news is it looks like we got more food. So there's there's plenty of food. So when we're done, anybody who wants to help. Do you guys have a question?
Sure, I have a question. Being rather self-serving, but with the audience, and you're speaking as far as using off-label, was that the proper term?
Yep.
With this audience, has your corporation considered doing something, or your business, or your company consider doing some sort of a trial with a group like this to find out if certain off-label drugs would be more effective?
So first of all, we're not a drug company. So
oh no, I'm sorry, I don't mean that. But
we're
technology.
testing. We make testing innovations. You know, like I said, I'm just now working out the kinks of this model.
Right.
And I'm writing it with a cancer advocate, and I hope to get maybe a patient to help me co-author it, and you get it published in and get the discussion going about this. And then I'm going to go to every drug company known to man, including the federal government, and say this is the way you should do it, and here's how you should do it. So
it's very exciting.
It's going to be a long haul, as I say. The way the insurers have developed their processes is a lot of them are pretty set in their ways. The actuaries are a strong group, but I think we can offer. And if not, I'll start my own insurance company.
But this is what you're asking, and what Dr. Billlings is saying is a perfect example of how, when you can get one person, right, to have this thought, have this model in their mind, and then go out and make it happen, and the difference that just one person can make. And the great news, like I said earlier, and I think my mom can attest to, is people, the technology being there, the drugs getting better and stronger, the patients having a voice are huge. And I know we keep saying it, but we cannot say it enough. We need your voices, the patient voice, the family voices, to stand up for all of this, for payer situations, for, even before we can get that to happen, to get you guys the testing that you need and the drugs that you need when you need them. We are one voice, but together we're like, by we I meant you and I guess that would make us two voices, but.
Together as a group,
yeah,
we're a huge force.
We can move mountains.
Moving mountains.
Yeah.
Well, then maybe just as a follow-up, my question would be, what are we able to do to be more supportive of your efforts to make this more of a reality?
So I think obviously advocating for yourself, if you have the illness or your family member has the illness, participating in research and talking to everyone about contributing their information so that their experience is gathered. So repositories of information, community research. And then in particular, if you've had an exam, I'd love to hear if you share them with me, if you've received a drug, an off-label drug as part of your treatment, and in particular if there was indication that you had a response. I'd love to know, one, that happened, and two, what your insurer did about it. Because the more examples I have of either good behavior or bad behavior, the better I'm armed when I go talk to them.
May I ask the question?
Please.
Okay, you say it runs about $10,000 to do a complete genetic analysis?
To do a whole genome.
Whole genome, yeah.
Between 1 and 10.
Between 1 and 10?
Yeah.
Okay. You can do 20 proteins for about $100.
That's correct.
Using a similar chip to the one you just showed us.
Yep.
Now, these proteins are produced by the codons you have in your genetic
Absolutely.
material. Can't you do a much cheaper analysis on proteins by tracing what proteins come from which codons and going from there?
Right. So eventually, we will know enough about the genes and their products and the messenger RNA levels and the proteins and all the ways that proteins get changed when they get made, that we probably will want to go to the proteins. But right now, genetic analysis is very stable. It does, while we've talked about the tumors do mutate and change their genes, it doesn't change as fast as the amount of the proteins go up and down, which really changes when you give someone some chemo. The proteins, a lot of those proteins go completely haywire. So it's a little more stable. It's a little more quantifiable. It's not the whole. And if I gave you the impression I thought whole genome sequencing was the whole answer, it's not. But it's a accessible, relatively stable kind of analysis that can be done now, and is adding a lot of important information. So what you say is true. Protein analysis is cheaper. Protein analysis is closer to the end game, but it's too variable right now to really be useful, I think, in many cases.
Thank
you. You're welcome.
Thank you, Dr. Billings.
You're welcome. It was really an honor to be here. I say that again.